I'm delighted to introduce our next guest, Dr. Max Wintermark, Chief of Neuroradiology and Co-Director of PNHW. His expertise is in clinical translation of advanced neuroimaging techniques. He has played an integral role in translating the center's mental health imaging pipeline to the clinic at Stanford. He joins us today to present on the clinical translation of a new mental health neuroimaging pipeline. Without further delay, I welcome Dr. Wintermark.
Thank you, Osna. Thank you for the kind introduction. It's my great pleasure to be one of the participants to this anniversary symposium today. The first thing I wanted to mention is I started at Stanford 7 years ago, and as I was starting, Stanford Neurosciences had an initiative about big ideas. And I got to discuss with one of the leaders of that initiative, Brian Wandel from the Department of Psychology. And I'm eternally grateful to Brian because he recommended that I talk to Dr. Williams, who had started a little before me. And I followed his advice, and I got to meet Dr. Williams and to learn about the great work that she's doing. I also got to meet with the absolutely wonderful team that she has assembled. And I got to learn about this revolution that she's leading in the field of psychiatry with the incorporation of neuroscience, neurocircuit, and in particular, imaging in the management of patients with depression and other types of psychiatric disorders. It really caught my attention as well as my interest, and it piqued my curiosity because that's something that I'd been involved with in other fields, also involving neuroimaging. To mention one, brain tumor imaging we used in the past to obtain very limited imaging that basically told us very little about the biology of the tumor. Basically, we would see how big the tumor was, as well as how much edema there was around the tumor, and that was it. But in the last decade, we have seen the introduction of new neuroimaging techniques that are able to look at specific aspects of the function of the tumor. Like, for instance, here on that slide, you have a demonstration about how the brain tumor receives its blood supply. And it's something that allows you to differentiate between different types of brain tumor. It's also something that allows you to differentiate a brain tumor from brain tumor mimics. And it's something that can also help you determine very early if a certain treatment is effective against a specific type of brain tumor. So all those things that I learned from Dr. Williams about depression and about the role of neurocircuits in depression really resonated with what I knew from other fields. Dr. Williams was very kind to accept me as a collaborator, and we started working together on this project of clinical translation, also with Dr. Hack. My contribution to that overall effort is the experience with imaging and with imaging individual patients. And that's something that you need to think carefully about, because there's a big difference between imaging a large number of patients as part of a research study on the one hand, and on the other hand, imaging an individual patient and then using the information collected in that individual patients to make treatment decisions. Those two things are quite different. When you image a very large number of patients, then you have a lot of statistical method, and Dr. Totsi described some of those methods to you. You can basically take advantage of the large data set that has been collected, and you can extract some information that is going to give you a lot of information about the group of patients that you have enrolled in your research study. On the clinical side, on the other hand, we're dealing with individual patients. And so we need to make sure that the quality of the information and the quality of the imaging information in particular is of the same level as the one that you would obtain as part of a research protocol. And you need to make sure that it's reliable if you want to be able to use it to make informed treatment decision. Again, that's something that we have experience with in neuroimaging. I'm going to give you another example, which is the example of stroke. So the management of stroke has changed quite a lot, has evolved and improved quite a lot over the last decade. And in parallel, the neuroimaging that we obtain in patients suspected of stroke has also evolved quite a lot. In the past, at the beginning of the last decade, basically when a patient would be admitted in the emergency room with a suspicion of stroke, we would just obtain a non-contrast head CT. And the goal of the non-contrast head CT would be to differentiate whether we could see a hemorrhage causing the stroke versus whether we could not see anything causing the stroke. And that didn't necessarily tell us that it was a stroke causing the patient's symptoms. But again, that's the tool we had. It was the best tool that we had available at the moment. And you need help in a certain degree by differentiating those patients who had an intracranial bleed from those patients who didn't. And that information was used to select those patients without an intracranial bleed for treatment called TPA. And that TPA could be administered between 0 and 3 or 0 and 4.5 hours, which is a very narrow time window. Then we had a very large number of clinical trials that were conducted using new drugs, also using devices to remove those clots that are causing strokes. And those different trials that were positive basically allowed to increase the time window to treat stroke patient up to 12 or even 24 hours, really suddenly increasing the number of patients who can benefit from treatment and massively improving the outcome of these patients. But as you can see, all of those new trials came with new imaging criteria and new imaging requirement. And so in order to administer those new treatments, you couldn't just get your non-contrast head CT anymore. We needed to get more complex neuroimaging done, involving not just only CT, but sometimes also MRI, and involving, again, the imaging of some functional aspect of the brain, the way the blood circulates in blood vessels, the way the brain gets its blood supply. And again, all those different trials involve different imaging criteria that require the performance of more complex imaging techniques. And that's something that we worked really hard at Stanford and elsewhere to try to implement in our clinical practice. It involves different efforts. One of them, just to give you an example, is one of those targets that you can aim for in a patient with stroke is what we call the penumbra. The penumbra is the brain tissue that is suffering from this clot that is causing the stroke, but that is not dead yet, and that can potentially be salvaged if you remove the clot in a timely manner. The way this penumbra works is extremely complex, and there have been multiple studies that have been conducted at multiple levels. But when we treat acute stroke patient, time is of essence. We tend to say time is brain. And as a result, we need to quickly get at that piece of information. We need to quickly determine if a patient has this penumbra, this salvageable tissue or not, because that's going to influence whether they would benefit from those new treatments that I mentioned earlier. And so that conducted us to develop operational concepts. So we use imaging. The imaging is not perfect. It doesn't necessarily give us insight in all the metabolism and the pathophysiology of that penumbra, but it gives us some useful operational information that can help our neurologist and our emergency physician make a decision in terms of whether they want to treat the patient or not. And just to show you what it looks like, it looks that way. So you have we get first some vascular imaging. We inject some dye in a vein of the patient, and we image that dye when it crosses the arteries in the brain. And you can see that this patient has basically here what we call a filling defect. So there's a vascular segment that is not filling up with the dye, and that tells us that the clot is located in that location. That's the first very important piece of information, because we can see that the clot is proximal and can be reached by one of those retrieving devices that I mentioned earlier. And then we get perfusion imaging of the brain. And the perfusion imaging of the brain allows you to differentiate the tissue affected by that clot that we see on the vascular imaging that is already dead, that's the red tissue, from the green tissue, which is basically the salvageable tissue. It's the tissue that's suffering, that eventually is going to die, but that you can save right now if you're able to remove that clot in a timely manner. So coming back to depression and psychiatric disorders, we face now a similar challenge. There were several questions in the Q&A about obtaining an MRI, and especially a functional MRI, prior to deciding a treatment for patients with depression. You also heard from Dr. Totsi that it's a lot of data that is being collected. It's really 3D images obtained over time, so it's actually 4D imaging. And so what are the solutions that we are thinking about and that we have put in place in order to be able to offer that test on a clinical basis? So we have thought about that quite a lot, and I'm going to go through the different things that we have put in place as safeguards. So the first one is, in addition to the functional MRI, we're also going to get some structural imaging. The structural imaging is currently being obtained sometimes in patients with some psychiatric disorders, especially in the emergency setting, in order to exclude an organic cause to their psychiatric presentation. And so that's something that is quite important to continue doing. So that's something that we will continue doing. It's also important to know, because when you have one of those organic cause underlying the patient's symptoms, it might potentially interfere with the interpretation of the functional MRI. The functional MRI results may be different than they should, not necessarily because the neurocircuits are involved by the psychiatric disorder, but for instance, because the neurocircuits are displaced by this underlying cause. Here I gave you one example. So you have on the top row, a normal patient with normal brain imaging. And on the bottom row, you have a patient with a brain tumor called a meningioma. And you can see that this meningioma is quite large. It compresses the anterior part of the brain, what we call the frontal lobes. It can cause symptoms that sometimes can be confused with those of depression. And again, if you do a functional MRI in this particular patient with this large frontal meningioma, the results are, of course, going to be different and in a good portion because of the mass effect exerted by that large frontal meningioma. So again, in order to be able to detect those organic causes and to interpret our functional MRI with some perspective, we'll add some structural sequences to our MRI protocol. The other thing that we are going to put in place is a process to try to ensure the quality of the functional MRI. Again, as Dr. Totsi mentioned earlier, a functional MRI requires the acquisition of MR imaging data over time. It's very important for the patient to be compliant with the tasks that they are asked to do or not to do. It's also important for the patient, for instance, not to move in the MRI scanner, because if they move, potentially that could affect the results. And so one thing that we currently do for the functional MRI that we do for other types of conditions, such as, for instance, in patients with brain tumor, and that we will replicate for patients who will undergo fMRI for depression, is some kind of education process for the patient. We have indeed observed that for our surgical patients who come for an fMRI before brain surgery because they have a brain tumor, we can increase very significantly the quality of the functional MRI by explaining carefully what we are going to ask them to do during the fMRI. So we have prepared a video, an educational video that the patients can look at home the day before their fMRI. They look at it again on an iPad when they're in the waiting room, waiting for their fMRI to occur. And that training video basically explained them everything in terms of what they should expect from the test, what's going to happen, what they are going to ask to do. And again, when we studied that for our surgical patient, we again saw a very significant impact on the quality of the fMRI data we were able to collect, but also on the time it took to conduct the exam and the overall comfort of the patient, which is something that is extremely important. For our clinical care, we'll also use FDA-approved equipment. So we have a software to obtain the fMRI imaging. We have another software called EdSeri that will be using to process the data coming out of the scanner. And we have set up, and I see Osna showing up on the screen, so I know that I have to go a little faster. So we have also set up a whole quality control process in place to detect different things, to detect, for instance, if the patient starts moving in the MRI scanner. Sometimes patients fall asleep because of the buzzing sound of the fMRI scan. And so we want to detect that early so that we can potentially correct that issue on the spot, as opposed to realizing it after the patient has left the MRI facility. So a whole set of quality control processes. We'll come up also with a report to describe our finding. And I think for that, the main thing I want to say is that it will be integrated with the rest of the information that Dr. Hack is going to collect in our clinic. And again, our goal is not necessarily you get an MRI, you get a result, you know what to do. The situation is, of course, a lot more complex than that. And the result of imaging is true for depression and psychiatric disorders, but it's true in general. The results of imaging always have to be interpreted in context of the other diagnostic tests and the clinical presentation. So we'll make sure that that's indeed the case. So I think I just made it in time. Again, it was a great pleasure presenting today. It's a pleasure working with this outstanding team on this exciting project. And again, if you want to become involved, you have the information here that will allow you to do so. Thank you for your attention.
Thank you, Dr. Wintermark, for the deep dive into this new paradigm shift using circuit dysfunction types to inform interventions. Let's now move into the Q&A portion of our program, and we'll look to questions from our guests. If you have any, please type them into the Q&A section. And in the interim, were there any points that you wanted to touch base on when we can look forward to having this move into the clinic, Dr. Wintermark?
Yes. So we hope to be offering it very soon. It requires a lot of coordination on a lot of different parts. We have been working closely with the medical center. I think there was a question on billing earlier. So that's also an aspect that we are working on, because we, of course, want to make sure that that test is affordable for patients. It's, of course, going to be a process. You know, that's why we're translational program. We are going to learn as we go, and also the more experience we gather, the more we can show that our approach impacts positively patients' outcome, the more we'll be able to get traction with payers, reimbursement, and so it will also help really with the widespread implementation of the approach that we're proposing. And again, if you look at what has happened in other fields, that's also the way it goes. MRI in general is an expensive test, but we obtain it routinely for many conditions where it has been shown to improve management and outcome, and we'll hope that we'll follow the same path.
Thank you. We had a few questions. Oh, sorry, we have one coming in the chat. Thank you for your excellent presentation. Do you have any data on retest reliability for functional MRI for resting state and also the active fMRI tasks?
Yes, so that's something also that I didn't have time to go in a lot of detail, but that's also part of the quality control. That's something that we have been working on, and as part of that overall effort to make sure that our results are reliable in individual patients.
Thank you. Any other questions in the chat? Do you look at the oh, I seem to have lost that question. There was a question and I believe we just lost it. Sorry. So a few other questions we have on here. You focus on measuring brain circuits using functional MRI. Do we plan to include other measures like genetic information?
Yes. So for that, I'll defer again. Perhaps we can discuss in the panel discussion. I believe that when Dr. Hack presented all those different tests that she will have available to pick from, you know, in a, again, individualized way for each patient, I think that genetic test will definitely be one of the options that she will look at. And again, she'll be able to explain that a lot more eloquently, but I believe our plan will be, again, to really tailor the test that she picks based on what she thinks is going to have the maximum impact for one individual patient, the patient she's taking care of at the moment.
Perfect, thank you. I believe that is our questions, and we will just take a quick pause in between before we introduce our next speaker. Thank you again, Dr. Wintermark, for your wonderful presentation.
Thank you.
Thank you.